This video is nephritic versus nephrotic syndrome, and this is brought to you by Dirty USMLE. Let me give you an overview of kidney shit, as I like to call it. You have to know the difference between nephrotic and nephritic syndromes, what they actually mean, what those two terms that you see right there, what that actually means. And then you need to know the specific types of nephritic and nephrotic syndromes. This is incredibly high yield. This is a top 5 topic for any step 1 or level 1 exam. You guys have been commenting on a ton of my videos asking me to come up with a video for nephrotic versus nephritic, and I do apologize for having the delay go this long because I have really good mnemonics for these. I just was really unable to put them together and make a video for this because I've been swamped trying to create content for you guys. But alas, here is the video of nephritic versus nephrotic syndromes. This will be a little bit longer than most of the other Dirty USMLE videos, but I promise you I'm not going to waste your time. This is going to be efficient, high yield, and concise. So let's just get right into it. We're going to start with what the difference is between nephrotic syndrome versus nephritic syndrome. So nephrotic syndrome, first I'm going to give you the actual science, the overview, like what you need to know didactically, and then I'll, of course, give you the mnemonic. So nephrotic syndrome is categorized by proteinuria, hyperlipidemia, and hypoalbuminemia. Thinking about it strictly in terms of what's actually going on, you're pissing out a ton of protein, so you're losing a lot of stuff in the blood. I like to think of it like that. So hypoalbuminemia, right, less albumin in the blood, fits that picture. The other thing that you need to know is that you're going to get hyperlipidemia, and how you can think of this is that the liver decides, oh my God, there's nothing in the blood. I need to create something to fill that gap, that we're losing all that albumin, we're losing all that protein in the urine. So it makes lipids. So just think of it like that. That's nephrotic syndrome. When you think of nephrotic syndrome, and here comes the mnemonic, I want you to think nephrotic syndrome. The difference between the word nephrotic and nephritic is the O versus the I in the same exact position. So when you think nephrotic, you think nephrotic. You think of that big O, which is going to clue you into the fact that nephrotic syndrome is hypoalbuminemia, proteinuria, and then for hyperlipidemia, you just think of some fat chick with a big belly, and there's that O right there, guys. So nephrotic, you think of the O, hypoalbuminemia, proteinuria, and then big fat belly, hyperlipidemia. That's nephrotic syndrome in a nutshell. Let's get back to nephritic syndrome. So nephritic syndrome, you need to know, is categorized by hypertension, hematuria, and oliguria, which I think of hardly any urine, because I like to think of this as the 3 H's. Hypertension, hematuria, hardly any urine. Now, don't get me wrong. In both nephrotic and nephritic syndrome, you're going to have some type of kidney injury. So creatinine will be bumped up. BUN will be bumped up. You're going to have classic signs of kidney failure to some degree. But the key to differentiating nephritic versus nephrotic is remembering the 3 symptoms that go along with each. So in the case of nephritic, we think hypertension, hematuria, and oliguria. Now, when you think nephritic, you're going to think of the I. The I in nephritic is what differentiates it from nephrotic, which of course had the O. So when you think of the I want you to think of like your eyeball, right? Your eye, things that you can see. So nephritic syndrome are things that we can measurably see objectively on a patient. So hypertension, hematuria, and oliguria. Let me explain what I mean. Hypertension, you can see. If their blood pressure is high, you see it. Hematuria, if they're pissing blood, you see it. And oliguria, if they're not peeing a lot, well, you see that too, because it's a symptom that you can actually visualize when they tell you. Now, contrast that with nephrotic syndrome. You can't see their blood, right? You can't see hyperlipidemia. You can't see hypoalbuminemia. And you can't see proteinuria. You can't see those things, but grossly you can see nephritic syndrome. You see it because you see it with your eye, and nephritic has an I in the word. So that's the overview. That's nephritic versus nephrotic. Now we're going to get into the specific types of glomerular pathology that you need to be familiar with. Now let me preface this next part by saying that you do not need to know if these fall under nephrotic or nephritic. That shit does not matter. You will not be tested on what is it. What you'll be tested on are buzzwords and associations. So I'm going to focus on what you need to know and nothing more. Do not waste brain space on these pathologies. You learn the buzzwords, you learn what they look like under a microscope, you learn high-yield associations, and you're done. This is all you need, I promise. So we're going to start with post-streptococcal glomerular nephritis, or PSG. I'm going to give you the overview and then I'll give you the mnemonic, just like I always do. So PSG is a type 3 immune complex deposition disease. So these immune complexes are depositing in the glomerular membrane and it's fucking up the kidney big time. You're going to have a decreased C3, right? Decreased complement C3 protein. This usually occurs 3 weeks after a strep infection, and you're going to have a characteristic lumpy, bumpy complex deposition. This makes sense. If immune complexes, which are kind of like little balls of shit, little balls of immune complexes get deposited, then it's going to be lumpy, bumpy. And I'll contrast that with a different pathology later on. So what's the mnemonic? Well, PSG has 3 letters. So PSG, 3. It actually rhymes. 3 for PSG. This is all about 3s. So lumpy, bumpy, we've got lump 3, bump 3. C3 is decreased. That's easy. And this occurs 3 weeks post-strep. This is also a type 3 hypersensitivity reaction. How about that? Post-streptococcal glomerulonephritis is PSG, 3 letters, PSG, 3 for PSG. It rhymes, it sounds good, it sounds nice. Lump 3, bump 3, decreased C3, 3 weeks post-strep, and a type 3 hypersensitivity. How easy is that, guys? You just learned post-streptococcal glomerulonephritis in what, 2 minutes? Again, here's your overview slide. Review it if you need to. This is everything you need to know, nothing more. Know what that looks like under a microscope. Try to infer that that's lumpy bumpy. You see those kind of balls of lumpy bumpy crap in the basement membrane, but at the very least, know the big points that we just touched. Next, rapidly progressive glomerulonephritis. So I want you to know that many different renal pathologies result in rapidly progressive glomerulonephritis. So don't worry about like what the underlying disease is. Just know that this is the kidney disease. The high yield association is that this is really, really common in patients who have lupus, SLE. This is also known as crescentic glomerulonephritis, and these arrows that you see are pointing to the crescent formation. They kind of look like crescents, I guess, but how you probably want to think about this is you want to call this rapidly crescentic glomerulonephritis, and I'll touch on that in just a sec. Also, you want to know that loop wire lesions can be found in rapidly progressive glomerulonephritis. Loop wire lesions also occur in something called diffuse glomerulonephritis, but that is really a nitpicky point, and you don't need to differentiate the two. For all purposes of boards, diffuse glomerulonephritis and rapidly progressive are kind of the same thing, and they have loop wire lesions. Let's talk about the mnemonic. I told you that I wanted you to call this rapidly crescentic glomerulonephritis. So crescentic and progressive, like they almost sound the same, but you can call this rapidly crescentic glomerulonephritis, and that will clue you into all the high yield things that you need to know. So a crescent has the loop lesion, and the crescent and the loop lesions kind of look alike under a microscope. And loop, I always say lupus because literally that sounds like the same word. So I say rapidly. So let me slow down here because I'm kind of going off on tangents. But when I think of rapidly progressive glomerulonephritis, I say to myself, rapidly crescentic glomerulonephritis. Okay, a crescent and a loop is kind of the same thing. They're 2 different things under a microscope, but they mean the same thing in my brain as far as shapes are concerned. Loop sounds like lupus. So rapidly crescentic glomerulonephritis has loop lesions and crescents, and they're found in patients with lupus. Additionally, if step 1 or level 1 is really going to be annoying and test you on diffuse glomerulonephritis, that's totally fine because we call that difflupus glomerulonephritis. So instead of diffuse, we say difflupus, which cues us into loop lesions and patients with lupus. High yield point while we're on this slide is that one of the number 1 causes of death in a patient with lupus is kidney failure. You also have infection and heart failure, but kidney failure is always up there, so know that. Again, here is the slide with everything you need to know, but rapidly progressive glomerulonephritis is rapidly crescentic glomerulonephritis. A crescent looks like a loop. It reminds me of lupus. Patients with lupus get this. They have crescents, loop lesions, and they can also be difflupus in the case of diffuse glomerulonephritis, but it is basically the same thing for level 1 and step 1, so just keep that in mind. Next, Goodpasture syndrome. What the hell is this? Okay, this is a type 2 hypersensitivity reaction. You get antibodies versus a subcomponent of type 4 collagen, which deposit in the glomerular basement membrane. This classically involves the lungs and the kidney, and it gives you a linear deposition. And I told you earlier when we were talking about lumpy bumpy, the difference between lumpy bumpy and linear is that Goodpasture is type 2 hypersensitivity and it's linear. whereas a lumpy bumpy is an immune complex deposition, and that's type 3. So if you ever look at a glomerular basement membrane under a microscope, and you're looking at the histology and you see a very linear looking one, then you can make a guess if you need to that that's good pasture. But if you see little balls of shit, as I like to call them, that's probably immune complex, and that's where the lumpy bumpy comes from. But with good pasture, I want you to think two pasture. Good pasture, two pasture. You can think of good pasture as two words if that helps you, but good pasture is going to be two pasture. And just like we talked about one that was all about threes, good pasture is all about twos. It's a type 2 hypersensitivity reaction. It involves two organs, the lung and the kidney. So if they give you a patient in a vignette who's coughing up blood, whose creatinine is through the roof and is showing signs of kidney failure, you're thinking to yourself immediately, well, this might be good pasture. In addition, these are antibodies versus type 4 collagen. So what you want to think about is a type 2 times a type 2 gives you type 4, because we're sticking with this theme of twos here. And the last thing is, again, here's our overview slide of everything that you need to know for good pasture syndrome. Review it if you need to, but good pasture, I want you to think of the disease of twos. Now let's get into Alport syndrome really quickly. Alport is basically good pasture plus problems with the ears and problems with the eyes. It's the same type of pathophysiology. The only thing here is that Alport sounds like Alfort, so I want you to think Alfor. So I told you that it's good pasture plus ears and eye problems. So it's good pasture, which was all about twos, plus two more things. And when 2 plus 2 is 4, we're talking about Alfort instead of Alport. That's the mnemonic. This involves, again, lung, kidney, ears, and eyes. 4 things, Alfor, sounds like Alport. So if they give you a patient in the vignette who is coughing up blood, who has kidney failure, who is deaf, and who has trouble seeing, the answer is Alport syndrome. Next, Wegener's granulomatosis. So Wegener's granulomatosis has a positive C ANCA. It involves the nasopharynx, the lung, and the kidney. And when you think about Wegener's, you want to think about Weckner's. Now, this is not my mnemonic. I'm giving full credit here to Dr. Sitar, who is the author and creator, founder of Pathoma. He created this, and it was excellent. It works for everybody. So I'm giving him full credit here. This is not my mnemonic, but Weckner's, you draw a big C over a stick figure, and where the C crosses the stick figure are the organs that it involves. So it involves the nasopharynx and like the nasal area. So that's the kind of top left part of the C. It goes through the chest, or like that mediastinal area there. So it's involving the lungs, and then it loops up and would touch where the left kidney would be if drawn anatomically. So here are the arrows pointing to the involvement of Wegener's. The C cues you into the area that it involves, but it also cues you into the C ANCA. And it's really important to know that it's C ANCA positive, because there's some other pathologies that are actually P ANCA, and you don't want to get those confused because it's high yield to be able to differentiate the two ANCAs. But again, Wegener's granulomatosis, think Weckner's. When you think of that Weckner's, you think of the C, and then just you got the organs, you got the ANCA, you got everything that's high yield right there in one beautiful mnemonic. Shout out to Pathoma for that excellent mnemonic. Next, membranous glomerulonephritis. It's technically called membranous glomerular nephropathy now, and I'll change that on the next slide. But you need to know that membranous is associated with hepatitis B and C. It classically has a spike and dome appearance, and there's arrows drawn on that here. Pathologists name things for what they think they look like. I personally don't see spikes and domes here, but just know that because it is a big buzzword. So if they say spike and dome, you think membranous and hepatitis. If they say hepatitis, you think membranous and spike and dome. Just know these associations. The mnemonic here is kind of crude, so heads up for some of you politically correct flowers who are sensitive to everything. But the mnemonic is suck some dick to become a member of the club. So basically, to become a member of the club, you got to suck some dick. Well, when you give somebody dome, that's the street word for saying that you're giving them, you're sucking on their penis, right? You're giving them a blowjob. So spike and dome. You want to be a member of the club. Well, that's membranous. And who might be prone to performing sexual favors in alleys on the street in order to score some drugs? Well, that would be someone who might have hepatitis from some IV drug abuse. That's a pretty bad stereotype, I will say it, but it's just purely to remember this. So suck some dick to become a member of the club. Who sucking dick? That's dome. Member of the club? That's memberness. Spike and dome with memberness. Who might suck dick? People with hepatitis who want to score some drugs. Hepatitis, spike and dome, memberness. Know the association between those three. Of course, all people with hepatitis do not suck dick. I'm not implying that, but this is just a really good mnemonic, so don't take it the wrong way, guys. Okay, next. Membranoproliferative glomerulonephritis. Basically, still associated with hepatitis, so know that. It also has membrano in the beginning. So to be a member of the club, that's memberness. We're going to separate that mnemonic. This is said to have a classic tram track appearance. And you see it's a black arrow. It's a little hard to see in the image on the left. It's pointing to kind of the dual component of the membrane there. It's said to look like a tram track, which I put in the image on the right. This one actually does look like what it's supposed to look like. So if you see tram track appearance or you see an arrow pointing to something like that, it's tram track. And the way to remember this is that if you're proliferative, you're fast, like a train on a tram track. That makes just perfect sense. I don't even have to be dirty in this situation. This is just a good, easy mnemonic. Tram track, membranoproliferative, know the association of those buzzwords. Again, hepatitis is associated with membranoproliferative, just like hepatitis is associated with memberness. But let me just add that hepatitis is more associated with memberness. So just know that one. Next, focal segmental glomerulosclerosis, or FSG. This is associated with patients who have HIV. There is a focal segment of glomerular damage, so hence the name. It's focal segmental glomerular sclerosis. It's sclerosis in the glomerulus that's focal and segmental. And I'm pointing to one distinct spot on this slide where you see glomerular sclerosis. So it's very aptly named. But we did PSG number 3. In this case, we're doing FSG HIV. So you're going to want to say these to yourself a couple times so that you're comfortable with the mnemonic. But FSG HIV. Literally, I just want you to know that if you see a picture like this that's focal segmental, you think of a patient who has HIV. They love these associations. It's super high yield, and you have to know this. Top 5 question, I promise. What we're going to end on, I think this is our last pathology here. I could be wrong. We're going to do IgA nephropathy, also known as Berger's disease. This name will tell you exactly what you need to know. There's IgA deposition in the glomerular basement membrane. It also shares features with another disease called Heinloch-Scheinlein purpura. You need to know that this is IgA nephropathy. Please excuse that I put the tram track pictures on this slide. I did not mean to do that. They usually don't show you a picture of IgA nephropathy. They just will kind of present you with a patient who has Heinloch-Scheinlein purpura, which means they're peeing blood. They might have had a recent viral URI, and they have a purpuric rash and abdominal pain. And then they're going to ask you, what will you see or what will you find if you kind of probe into the glomerulus? And the answer is IgA deposition. So just associate these with one another. Again, you just need to know the name here. IgA nephropathy will give you the IgA deposition. If they give you a patient with Heinloch-Scheinlein purpura, you just need to know that it's IgA. There's really no good mnemonic here. It's just something that you have to memorize. I apologize. Next disease is minimal change disease. Minimal change disease is common in children following a URI, and the slide classically shows foot process effacement, also known as podocyte effacement. Basically, it just means that the foot processes, which are normal, or found normally in a glomerulus, they start to kind of disappear or kind of phase out of their normal geometric orientation. The way to remember this is to say minimal, right? It's called minimal change disease. Well, kids are a minimal age. So minimal change disease is the most common in children. What's the most minimal body part on the body, or the most, closest to the ground? That's your foot. And you have effacement of foot processes. So when I think of minimal change disease, I think of the minimals, right? Kids are a minimal age. The feet are the most minimal part of the body, which in my head means closest to the ground. Kind of easy to remember. Just know that minimal change disease is minimally important. There's really not much that you see. The only thing you see is effacement of foot processes, and that's the highest yield point. They love to ask you, what do you expect to see in the glomerulus? And minimal change, the name is telling you that there's minimal change. There's really nothing there. You just have effacement of foot processes. Here is a summary slide of everything that you need to know from this video today. These are a summary of the buzzwords. In review, minimal change disease, know that it occurs in kids, and then you have effacement of foot processes. Focal segmental glomerular sclerosis, FSG, HIV. Know that it occurs in HIV patients. Membranous, you want to be a member of the club, suck some dick, which means give some dome. Who might do that? Patients with hepatitis looking to score some IV drugs. Membranoproliferative, proliferative means you go fast. Like what? Like a train on a tram track. Post-streptococcal glomerular nephritis, lumpy bumpy. Remember, PSG, all about threes. Lump 3, bump 3, 3 weeks after a strep infection, type 3 hypersensitivity, decreased C3. Also worth mentioning, in post-streptococcal, you have an increase in your ASO titers. That's just something you should memorize. Wegener's is Weckner's. We think about Weckner's, so we remember C. ANCA. In addition, that C is Dr. Satar's mnemonic for remembering the organs that it involves, right? Nasopharynx, lungs, and kidney. Beautiful mnemonic. Rapidly progressive, we say rapidly crescentic. Crescents and loops, kind of the same shape. And loops like lupus. So SLE patients will have rapidly crescentic or rapidly progressive glomerulonephritis. And then IgA nephropathy, of course, you have IgA deposition. And what disease is that associated with, guys? That's going to be Hemlock-Scheinlein purpura. So know that association. But this is your summary of buzzwords. This has been a super, super, super high yield video. And I hope that you guys can make use of these mnemonics, but don't study anything else than what I've gone through today. Know what they look like under the microscope. Know these buzzwords, know the high yield associations, and you'll do more than fine on your USMLE or your Comlex. Good luck.